Welcome to the Inside the Boards podcast, the podcast dedicated to helping you learn to think like a question writer so you can study smarter, not harder, and succeed in medical school. And now here's your host, Patrick Beeman.
All right, so we are back one more time with Panacea Financial, our generous supporter for this health system science series. Panacea Financial's Dr. Ned Palmer, world-class med-peds physician, real-life doctor. You're the chief strategy officer for Panacea Financial when you're not practicing medicine. And today you are our interlocutor answering the question, how do I transition to and pay for resident life? I should probably start thinking about this because it's like February of the academic year. And if I'm a fourth year, that time to move is coming right up.
Thank you, Patrick, again for having me here. It's been so exciting being with Inside the Boards and the Health System Science Series. It's so great to see what you guys have been putting together with the curriculum in this, I think, really interesting developing space for medical education. And I'm super glad to see that this is becoming a focus of med student curriculum. So really excited to partner with Inside the Boards and be ahead of the curve in terms of medical education curriculum. The fourth year of medical school can be an incredibly and surprising expensive year.
Totally the best year, but
it can also be incredibly expensive. We're talking about this in February of 2021. This has been what I hope to be the weirdest residency interview season ever. Ever. Let's just set this as the weirdest, and it never gets weirder than this. So already this whole year, basically right from the summer that starts your fourth year, is you're having to spend a load of money on residency applications. You then have to look, if you haven't done it yet, on Step 2 CSCK, the COMLEX 2 exams, depending on whether you're an MD or DO student. You've got to start putting money out to the tune of thousands of dollars. And that's before you even hit the interview trail, if there's an interview trail. For instance, the year that I went and interviewed, I took 18 interviews in 16 different cities and spent about $9,000 to find my med-peds forever home in Cincinnati, which is, and so there's just all year, there seem to be these expenses that dig at you and just come out of seemingly nowhere a little bit, are always more surprisingly expensive than they should be. And then you match. And you've got this wonderful day in the middle of March and the future is laid out and you finally see what's going on. And then there's this realization that now you have to move after this entire year. You've already spent $10,000 or $15,000 getting to this place. And now you're looking at taking all of your stuff, going to a new city, paying first and last month's rent. When I moved, I had to pay for licensure and credentialing and get it reimbursed. So I had to put a couple of $1,000s on my credit card and wait for reimbursements. On top of all the moving expenses, there are just so many financial shocks during the fourth year that it can be a really challenging time and unfortunately set up a high level of stress getting into your intern year, which is already a terribly stressful year from a work environment.
Decently stressful, I can attest.
Decently stressful. And especially now with this being the weirdest year ever, that hasn't made intern year less stressful. That has made moving harder. It's made just everything more challenging. And so there's important things that med students can do during this fourth year to try to protect themselves as much as possible. And if nothing else, know where resources are if you need them.
Yeah, I mean, everyone knows, you guys are financially supporting our series, which helps, basically pay Chris and Madison, who help make this stuff possible. But we're all helping each other, and Panacea does have a solution for this difficult time in the fourth year. And that's one of the things that we want to be able to tell our listeners about, because we think it's super helpful if you're in that state of dropping 10 thou on all the, interviews. Although I would say probably that is maybe the only good thing with 2020's COVID-19 pandemic is a premium Zoom subscription's like $10 a month. So if you can do all your interviews on that, there's one way to save a couple thousand.
Yeah.
But I can't think of really anything else. Yeah, that's really tough to spin positive.
Step 2 CS, I think, is still on hold as well, and that saves money.
Oh, is it?
But they haven't figured out what's going to come next, so that's may only be a temporary savings. I guess all I have to say on that is we'll see.
Yeah. Oh, but sorry, tell us about the PRN loan for our fourth years.
Absolutely. So the PRN loan is exactly as the name would indicate. It's your money as needed. We understand better than anybody about these financial shocks, how they come up, how they seemingly are always surprisingly more expensive than they ought to be. And that's why we designed this loan for fourth-year medical students, as well as for residents and fellows, to be able to access funding in a fair, cheap, and quick way. Because it is so frustrating to be asked to go have your parents co-sign a loan when you're a med student and you are very much an adult. It's so frustrating to be offered twice the rate because you took out a lot of medical education debt and the traditional banks penalize you for it. And it's really frustrating to be wasting time doing these things, being rejected, being asked for supplemental information.
Yeah.
And that's why we designed our product to be able to get you money in as little as 24 hours. We want to be there for the medical students out there across their career.
Nice. I was in the military, so the financial, it wasn't perfect because, like, you know, making $20,000 a year at the time, like a decade ago, it wasn't a lot of money to support a family. But at any rate, I remember applying for a mortgage as a good example of a loan and trying to explain like just what was up to different like mortgage companies after I got like a preliminary approval and then a almost immediate rejection or a pending rejection unless I could prove like this, that, or the other thing. Half these companies, they just looked at like a debt to income ratio, which I didn't have that much debt except for like undergrad, but I didn't look that great financially. And then, you know, like 2 months later, I looked way better when I was a military resident because we made a little bit more than the average civilian resident. But still, just that whole thing you said about having to get supplemental information, that's so annoying. I hate that. I'm applying for a mortgage now too. And I was like, oh, wow, that was pretty simple. I like had my I had my tax returns, had like my pay stubs, had like checking account statements. And I'm like, all right, cool. I'll send this off. And they're like, oh yeah, okay, looks good. Oh yeah, but we also need all of this. And it was like a list of like 20 things. And it's just super annoying. And it's like in every financial kind of context, things like this pop up. So if you guys are helping solve that or make it a little less painful, good on you.
I think a huge part of the value is getting what you're going through. Instead of trying to explain to somebody what an M4 is and how you came to have finances like this and how it's actually a sign that you've got a great and stable financial future in front of you, you're going to get looked at by somebody who doesn't understand it and evaluate you through traditional lens and only see risk and not see any of the benefits of the hard work that you've put in.
Yeah, well, this concludes, I think this will conclude our little series of talks about how Panacea Financial can help medical students. But we'll end up doing another episode about Panacea itself and more so about kind of financial literacy and healthcare economics here in the future. Very soon. But for now, I urge you guys really to go to panaceafinancial.com/ITB and really explore what a bank built for doctors by doctors can do for your financial life. That is Panacea's, I would say, probably almost mission. Hey, if I could be so bold.
Be bold.
Physicians like yourself are building a bank for doctors and med students and to take care of our kind of unique financial lives. And that's just awesome to me. So go open a checking account or apply for a PRN loan if you're in the market for that and have the need. panaceafinancial.com/ITB. Panacea Financial, a division of Sona Bank, member FDIC. Thanks again, Ned. Appreciate it.
Thank you very much, Patrick.
All right, well then let's dive in on the Inside the Boards podcast. I'm Patrick Beeman. I am an OBGYN, among other things, and I'm here today with Dr. Heidi Gullett and third-year medical student Andrea Szabo. And I'm told Gullett Gullett rhymes with mullet, which I think is an awesome way to put it when people are going to pronounce your last name. But Dr. Gullett, you are, I have rarely seen so many academic positions and faculty chairs and things that you're involved in. What do you say you are?
I say that I'm a family and public health physician, faculty at CASE, and I am a wife and mom.
Nice. All right. And you are also, just interesting to the students who listen probably, you are involved on the board of directors of the NBME. So, but we won't try to get any secrets out of you. But everyone thinks you guys are trying to trick students on the exams, but I try to tell them you're not. But are you? Are you trying to trick students?
No, not at all. It's about making sure that people are safe to practice for the public. It's about public protection and safety, and it's about fairness. And I've been an item writer for the NBME for many years, probably 7 or 8 years now. And so I appreciate that part of my work too.
Well, there you have it. They're not trying to trick you. Next up, Andrea, you're a third-year medical student. And besides being a third-year medical student, what else do you do? Are you proud of? What's your background?
Yeah, I am pretty happy to be back home, going to school at medical school at Case Western Reserve University. I think some of the things that I'm proud of at school are basically our past year working at the Cuyahoga County Board of Health and with our COVID-19 response. And then otherwise, I think what else keeps me really busy at the medical school is our annual showcase of Doc Opera, which helps support our student-run health clinic.
Doc Opera? Nice.
Uh-huh.
Yeah, that sounds cool. So thanks to the AMA and Elsevier for supporting us with some content and connecting us with our guests like you guys. Today, we're kind of here to talk about, we could say HSS in general with kind of a focus on systems thinking or leadership. I'm not sure really what Maya assigned. We threw together kind of a very simple syllabus. But the reason she connected us was because you guys started a project at the outset of the pandemic related to our local health department. And that serves as kind of a springboard to our discussion today. And so I guess I'd ask Andrea to start. What is this project you guys did at the local health department?
Yeah, absolutely. I'd love to talk about it. So I was pretty lucky that I did some of my research at the Cuyahoga County Board of Health. So I was invited to, kind of participate and see what the pandemic planning and things like that were all about at the Cuyahoga County Board of Health. And when I got there, and of course, Dr. Gullett was working there quite a bit, there was definitely quite a need for developing a contact tracing program, especially as our cases started to climb and things like that. Coming from our background with health system science and, the systems thinking, we knew that we needed to involve more of a workforce. And at the same time, medical schools were really scrambling because a lot of their students were getting pulled out of clinical activities. So it paved the way for a really good relationship for medical students to come into the Cuyahoga County Board of Health and help develop that contact tracing program. So that was kind of what we were really working on. In addition to the contact tracing program, we also kind of developed a cluster investigation team. So whenever we were identifying that multiple cases were happening from a certain event or certain place, we kind of attacked it a little bit more aggressively and made sure that we were providing good guidance to wherever this cluster was happening. And it also helped our contact tracing efforts in that sense.
Got it. And I would think contact tracing as a concept helps illustrate some things about why doctors need to be systems-based thinkers. Dr. Gullett, can you speak to kind of how contact tracing, or that the program specifically you guys set up, illustrates the importance of systems thinking?
Absolutely. So systems thinking is important for all kinds of medicine, but I think it's been readily apparent over the last 10 months in the COVID pandemic how important understanding systems and thinking through systems and adaptations within systems can really help improve the health of both individuals and populations. And so one of the most important things we talk about when we have med students in our practice is that it's really critical to think of patients in context, individuals in context of family or the community, their environment. And so when we started doing contact tracing, that was critically important. And so we had some forms from the CDC about what information they wanted, but we really quickly realized we needed a lot more information to make sure that people were safe at home. We gave them resources that they might need, but that we also considered how connected our world really is. And we needed to make sure that they were able to connect to a high level of care if they needed it, but also we needed to contact all of their contacts and find out how to keep them safe too. And so systems thinking was really probably the most important thing that we utilized at the beginning and throughout, and are still using as today we're trying to figure out how to give our vaccines and get our vaccines deployed. So lots of examples.
Yeah, totally. So, and either of you, I'd like to, as much as we can, hear from Andrea, because med students are, kind of why this podcast exists. But what components, like what is a system to you, to put you on the spot? This hopefully is some less or more gentle pimping than you'll see on the wards, but...
Yeah. So the system definitely that we were working with, it's kind of complex because there's really so many systems within the system. So, we were in the system of just making contact tracing that was my biggest system that I worked as a part of. But, there was also a context of the resource team was also a system to provide resources to those that we were helping with contact tracing. And then the hospitals were kind of their own system, but really they were all nested in this even larger system. So that really kind of demonstrated to me the importance of, all these little parts in the system, but also all of their collaborations in order to make things happen. And we found that, as the pandemic kind of went on, kind of the way that we went about things, changed a little bit. So at first at the health department, we were like really important in providing just general guidance because a lot of people didn't know about COVID-19. And then eventually, our role kind of changed to be more of the contact tracing. And then at one point when there wasn't a lot of testing, we were involved a lot with like the testing strategy and how to do things like that. So, for me, the systems were, the parts, how we were all kind of connected to each other. And then also just kind of how our roles shifted and adapted over time based on the need of our community.
So was this your initiative to get med students involved? You were thinking like, oh man, now we're not going to be on rotations and we're still paying like $100 an hour for the next year for school. May as well find something to do, or...
I think it was a little bit of a combined effort from a lot of people. I know Dr. Gullett definitely had the vision to invite some medical students to come in. And then there were also some medical school administrators who were like, where can we send students so that they can get these hours? And then I think, after we started getting some students in the door, then I tried to help step in because I had actually taken a year off for medical leave. So I was able to be at the Board of Health and kind of help organize and train students and kind of be there to make sure that, changes from day to day were being relayed to the new set of students coming in.
And from the time you guys kind of like had to stop rotations to the time you started having med students involved in helping at the health department with these things, like how long was that?
So I actually started helping at the health department before everyone was cut out of rotations, but then I would say probably within a week, students were cut out of rotations. And then shortly, I would say within the next few days, we had students in the Board of Health.
So, Dr. Gullett, I imagine that you guys have some infrastructure then that makes it easy to implement things like that. But how did you view integrating students into the work that needed to be done to review cases, do the contact tracing? Like, was that your first thought? Like, we can use the med students' expertise to kind of do this kind of work that would otherwise probably just have a very tough time getting done? I don't even know what I'm asking there, but I just love that the students were involved. I often tell students when they would rotate with me, it's like, remember, you guys are adults and you've already, done like 2-3 years of graduate level work. So you have a lot of expertise you probably don't give yourself credit for compared to the, regular old public. And it seems to me this is a really cool way that you guys were able to deploy that. So I don't even know if there's a question there, but.
Well, I would just say that, I really like how you framed that. And for me, students are brilliant and inspiring, and we need to give them opportunities to shine at every level of their professional development. And so it was not even a question for me that we had a need and we had a group of incredibly talented folks ready and willing to help. And so we needed to bring those together in a system that was functional and engaging, and that where we built trust in a really difficult and stressful time. And we were able to help everybody really work to the level of their training and their talents, and to also be part of the constant systems evolution that was part of these processes. We built this plane as we flew it. Like, there was no playbook. I mean, and there still isn't. I mean, we're just figuring it out as we go. And so it was our students at the table every step of the way, at tactics meetings twice a day, giving feedback about how they think we need to change the workflow for this or that, and what we need to do here and what's missing here. I mean, that to me was energizing as an educator. And that's the way I think medical education should be.
Yeah, absolutely. It's nice when you're inside a context in which you can look at what your work flow or work life is like on the front line, and be able to offer input that people listen to. I think that encourages something that gets different words in different contexts, but a creative spirit, entrepreneurial spirit, leadership, and enabling students to do that. Also, I mean, it just makes sense too. I think a lot of people who've been a med student and then gone on to teach students realize that sometimes just having that fresh set of eyes that has not been influenced by years of certain habits that you develop as a doctor can shed light on anything from the way you practice and document to the way you treat patients, ask them questions, or otherwise figure out their diagnoses. So that's pretty cool. And I like that. I 2 thumbs up or whatever to Case Western, which I was going to actually do their JD-MD program back in 2006 when I matriculated to the University of Toledo. And the reason is that I didn't go to Case was people talked me out of, kind of, thank God now I say, of doing a dual degree at that time. That would have been just too long. I could not have handled all that schooling straight away. Looking back though, if I never had to get a job and I could just keep like learning and doing like degrees and whatnot, I'd probably do that. But unfortunately, we can't. Eventually, you have to give back and contribute, which you guys are doing. So we've got a bunch of cases here, again, from Elsevier's HSS review book. Unfortunately, some of these are not quite NBME level questions, the sorts of things you would exactly see in format on the USMLE or another standardized exam in med school. But nevertheless, they're illustrative of some of these HSS concepts that we're tackling throughout this series. So would you guys want to move into that at this point?
That would be great.
All right, perfect. And then I will say before we do that, Case 3 is kind of unwieldy in terms of its stem. I'm fine with that. And it's just up to you. But if you do think it's a little too complex for audio consumption, we could probably just, define a complex adaptive system.
Yeah. I mean, I think it is a little bit lengthy, but.
And I think that's fine. I mean, it's a story too. So it's not like you have to keep in mind a bunch of, unique, pertinent positives or negatives. So would you want to read the case and go through the STEM and answer choices, and then
Yeah, I can do that.
And then we can punt to Dr. Gullett, walking us through the answer choices, why one is correct over the other. Because what I usually do is a primary care clinic, go through the case, and then the question we're being asked here is, how does this clinic demonstrate a complex adaptive system? And we've got A is this, B is that. And then either we will pause there and just give the straight up answer, or return to the STEM and go through, how to break this down. I don't think it really matters as long as we're able to communicate, as I say, something that students can take away with them from the episode and, go into the test center with.
Sounds good.
Well then, Andrea, I will ask you to take this first case that we have here. It's a little lengthy, but, listener, just if you got to pause, you can do that. And it's a story. So let's hear this story.
All right. So this is case number 3. A primary care clinic decides to implement an EHR for the first time. The first year after the EHR is put in place, the clinic receives approximately 1,000 messages a month via the EHR. A year later, the number has increased to 10,000 messages a month. The clinic is suffering from high employee turnover, both among physicians and nursing staff, who are struggling to handle the influx of electronic messages. To address concerns, the clinic manager assesses all the messages coming into the clinic and divides them into categories like prescription refill requests, urgent concerns, requests for forms to be filled out. The manager then holds a meeting with all of the staff to get agreement on which of the staff should be addressing which category of messages. After discussion, the staff agrees that physicians need to answer urgent concerns, the physician assistants will address prescription refill requests, and nurses can fill out most of the paperwork. The manager then hires a triage staff member to ensure the messages are sent to the appropriate person. After several months, the manager checks in to assess staff member burnout and finds the situation has improved for nurses and physicians, but the physician assistants are still being overwhelmed by prescription refill requests. The manager reviews the data and finds that renewing controlled substances is taking the most time and causing the most frustration. Therefore, refills for controlled substances are sent directly to the patient's primary care provider. The question is, how does this clinic demonstrate a complex adaptive system? A, the clinic chooses not to reassess or iterate its messaging process. B, the clinic manager employs hierarchy to make decisions unilaterally. C, the clinic adapts multiple times to an increase in work that previously did not exist. Or D, none of the above.
Yeah, there's a lot there.
There is a lot there.
Dr. Gullett, you've got all those titles as an educator, so walk us through how to answer something like this and think about a situation that sounds kind of real life.
Yeah, absolutely. So when I first read this case, I was like, I think they came to my clinic and they wrote a story about us because it was incredibly realistic. So it resonated with me a lot. So when answering questions like this, a lot of times in medicine, we use jargon. We use these terms that don't mean a lot to anybody outside of our narrow sector. And sometimes that can divide us from other people and other colleagues. But we have to figure out how to do that, and test taking is part of that. So thinking about complex adaptive system, you really want to think about what are the ways that a system can move and change to all of the different inputs around it. And I think one of the things that Andrea and I both thought was that this question, so not just this vignette, but the discussion that we talked about earlier of our work at the Board of Health, is really a complex adaptive system. And so when you're thinking about answering questions like this, you want to think back to okay, when I was on the wards or when I was in this health system, what did I see? I was rotating here. What did I see? And how did I see quality improvement changing, or the system adapting to be a way that provides for better infrastructure and systems changes to help people be healthier?
And I will say too, in the NBME content outline, it does talk about systems-based practice in specifics, what students should end up knowing. And one of those is understanding the complexity of systems and systems thinking, and how complexity, for instance, leads to error. And they also ask students to know about the organizational behavior and culture. So I suppose that could be workplace design and processes, the different staffing roles, EHR specific choice and things of that nature. So this too is, believe it or not, it's relevant. I guess I'll ask a leading question just to follow up on what you just said, Dr. Gullett. Is health system science an afterthought?
It is not. It's actually the way that we care for people, individuals, and the way that we care for communities and populations. And so if it is taught as an afterthought, and it is not going to be successful in helping people understand how they are agents of change in a system, as medical students, as residents, and as physicians in practice, we are going to be in systems our entire life. We already are. But as you progress through your development as a physician, you are an agent of change at every step of the way. And so health systems science is equipping learners with the tools to be that agents of change in a system that sometimes seems broken or frustrating or overwhelming. We don't want it to be that. We want you to see what needs to be changed and adapt the system to be better. Absolutely.
And so I don't know, I wasn't, I kind of spaced out for a second, but do we give the answer for how does this clinic demonstrate a complex adaptive system, which was choice C? The clinic adapts multiple times to an increase in work that previously did not exist. If we didn't, there it is. Anything more to say about that particular question?
Nope, we're good.
All right, Andrea, what is the follow-up then for this case? There's another question that this book is asking us to think about.
Yeah, so the follow-up question is, how did the clinic manager first engage staff in the discussion of how to address messages? And your answer choices are A, the manager had a meeting to address mental models about which group should address which message. B, the manager gathered data on the types and numbers of messages that the clinic was receiving. C, the manager came in with a plan for how to address the messages and communicated that to staff. D, which is both A and B, or E, which is all of the above.
Yeah, well, this one makes me thankful that they don't do these sorts of questions on, usually board type exams within medicine generally, and certainly not on the USMLE. But the answer choice here is both A and B. And Dr. Gullett, can you walk us through why it's A and B and why C, which was the manager came in with a plan for how to address the messages and communicated that to the staff, is not only not the answer that would be scored correctly here, at least in the HSS review book, but also not like an optimal approach.
Yeah, absolutely. So systems are designed, and they get the results for the way that they're designed, right? We can talk about that in a lot of contexts, but people work within those systems and they can adapt things within those systems. And so if you have a manager who does what C is, which is they come in with a plan and they just tell everybody how it's going to be, the engagement of people working in that system will not be the same as if the people who are in the system have an opportunity to share their own mental models, their own way of thinking about how they see themselves in the system, and also about what needs to change. So gathering data on what's there. Doctors, I think, are notorious for thinking that, they do things better in systems than they do, right? And then we get shown data and we compare to our colleagues and we're like, oh, no, I didn't close my messages in a certain amount of time. Or, I guess, I can't argue with those data, right? They're there. But you really do have to have a combination. A lot of times in public health, we say head and heart approach. So we give people data that speaks to their head. But we also work with their heart, and we want to know what they're thinking and how they see things changing and how they want to engage themselves in making things better. So that's why it's A and B. And that's why, people have to be very relational in systems in order to help them improve, and to see patient safety also be a big part of that is really important.
Yeah. I noticed you went to Wright State University in Dayton, right?
Yeah, you did a lot of research about us before this podcast, didn't you?
I'm not going to lie. I did. I just Googled your names and looked at like the top 2 results. So I'm a fast reader. Plus, you have that page on, your CV it's a book, man. And you guys got some press too, Andrea, for the project you did that we were talking about. But to return to Dayton, Ohio, I did my residency at Wright-Patterson Air Force Base. And so the military base, military in general is a very hierarchical system. But in my 7 years in the military, I even found there was definitely the necessity of, I don't know, I don't want to say fudging the hierarchy. Well, yeah, in one sense, figuring out how to balance the hierarchy of authority that occurs within the ranks of the military and, the collaborative processes and nature of the work that individual teams had, like, for instance, in our OBGYN flight. I was the medical director. We had a flight director who handled more like administrative stuff. We had some NPs or midwives and other physicians. We had, the equivalent of all the things you'd expect within the context of a practice. And it just, goes to show, even I can just think of so many situations where it just would not have worked, absolutely would not have worked for somebody to come up from on high and be like, this is the way it's going to be done. Now, sometimes they did do that and would have to for, non-compliant message openers, I suppose. You need, I guess, that sort of accountability. But even in the context of the military, this sort of systems-based thinking and less hierarchical model seems to be almost necessary to continue things moving and improving and adapting. So this makes a lot of sense.
And I did my 3rd year OBGYN clerkship at Wright-Pat.
You did?
I did.
Can I ask what year that was?
A long time before you were there.
So I was there 2010 to 14.
Yeah, I'm a little older.
Dr. Campbell, Mark Campbell, was he there at the time? You might not remember all the faculty. Some were there like longer than they were supposed to be from a military context, but I bet that was a good rotation. It was really good when I was there as a resident for students. They got to do a lot of things, more than, unfortunately, I think students get to do in a lot of other places nowadays. But
yeah, it was a little hard as a civilian because it was right after 9/11. So that tells you how long ago it was. So I have to go really early in the morning to get through security as a civilian because they would take the mirrors around my car and
Oh yeah, I forgot about that. Yeah, I didn't have to worry about that. My wife went to Wright State, and she's psychiatry, but she had to deal with all that stuff too. At any rate, let's I guess return to our case here. We are on, I guess the next one we don't have a case for, but it's a question worth thinking about. So, and this question is, systems thinking links a person's environment to what characteristic? And what are the choices here, Andrea?
Our choices for this one are A, skills, B, knowledge, C, behavior, or D, all of the above.
All right. So what's the answer?
The answer for this one is C, behavior.
Okay. And how does behavior link a person's environment to systems thinking? Or how does systems thinking link a person's environment to their behavior?
Yeah, so I actually had a harder time on this one. But for me, I think it was really helpful to think of the relationship that there is between kind of the structure of a system and someone's behavior. So I often relate it kind of back to how Dr. Gullett said, thinking about our past experiences, I often relate it back to kind of my time at the health department and how the needs in our systems were changing with time and how, our structure of the system, at first we didn't have, testing happening at hospitals as much. And so it was really kind of up to the health department to be going into residential care facilities to do this sort of testing. So for me, kind of the structure of how the system was made kind of influenced how our behavior was and how we could address all these needs in the system.
Makes sense. Anything to add there, Dr. Gullett?
No, I think it's just really important when you're in training to think about how you're influenced by the system, but also how you can influence the system. It's a two-way thing. And I think that when you think in systems, sometimes you can see how big the problems really are. But then if you look at a smaller microsystem level, you can see that you could be the one that's contributing to that patient safety issue in a really positive way. Or you could be the one that thinks about how we redesign a workflow so that it works better or it's more efficient. So it really works both ways. And it's not, hopefully for trainees, sometimes they may feel like they don't have autonomy. But I hope when thinking about systems thinking, it's a tool to empower you to work differently, to work more efficiently, and to work in ways that really utilize your ways of thinking and the lens that you bring to the work.
Yeah, and it's probably as little as it may feel like this. That's part of systems thinking is part of the ACGME's kind of educational goals for all residents, and probably the LCMEs too, but I haven't looked at that stuff in a long time. Can you think of an example in your own projects related to the public health, contact tracing, and COVID-19 stuff that you guys all implemented that would illustrate how students specifically could be change agents, or how the system adapted to something unexpected or otherwise got changed because of somebody's systems-based thinking? Either of you. I'm not sure who would be best to field that question to, but
Dr. Gullett, do you have thoughts on this one?
So I'd like to talk about Andrea for a moment.
Oh, she can hear us.
So there were many occasions where working through the COVID-19 response, we would meet twice a day in tactics meetings at 9 a.m. and 3 p.m. And we would work through our workflows. And sometimes those were in painstaking detail at the micro level. And sometimes they were linking to the 30,000-foot big picture. And we have here at the health department where I'm at right now, where we spend a lot of our time, we have a big dry erase wall in one of our team rooms. And we literally would cover the dry erase wall. And we would draw linkages and we would make lists, and we would, really try to organize our thinking. And Andrea, many times stepped up with solutions and interventions and workflow changes that really steered our course differently and enabled us to actually meet people's needs where we were blinded. But because she was on the phone and she was hearing patterns of what people were saying, she was able to bring to tactics and say, okay, I really think we need to focus on providing people resources for this because I'm hearing this repeatedly. Or I've seen a pattern of infections that came from this location, or this particular cluster is linked to, some events that happened. So it was really, I can just tell you example after example of how she really, as one person, was able to use her systems thinking to change the course of our response in real time. And there has to be psychological safety when you are in those high stakes environments. But we had trust, and we trusted one another, and her voice was equal to everybody else at the table. So, or I hope she felt that way. I don't want to project that. So Andrea, I don't know, you're very humble, and I know you don't talk about yourself a lot, but there are a lot of examples. So you could follow up on one.
Oh, we should make you do it then. Give us an example. Put your feet to the fire. Can you think of something that you were able to, that would illustrate this point here?
Yeah, you're really putting me on the spot. Thank you very much, Dr. Gullett.
Do you want to talk about what you did with the state?
Yeah, sure. I could talk about that. I don't even know how it came up, but somehow we were contacted by the state, and that they had heard about the contact tracing program that we had in our county. So the Ohio Department of Health reached out to us because they wanted us to provide some tips, because we had been on the front lines and been doing the contact tracing, and they were hiring a bunch of folks and training them. So they, wanted to get our input since we were on the front lines, of calling those folks. So myself and then another preventative medicine resident over at University Hospitals helped me. We kind of put together a nice PowerPoint and led a few training presentations for these Ohio Department of Health individuals, just kind of going over basic interview skills and, how to ask certain questions, kind of some issues that folks often run into. But I think there was multiple experiences, at the Board of Health where, there were a lot of students who wanted to, help contribute more. And they were, like Dr. Gullett said, they were always up there at the tactics meetings talking about different changes that we could make in the flow or, needs that needed to be addressed by folks.
I forgot to ask earlier if I were a medical student or even, for contact tracing, my level of knowledge would be probably even behind your current day med student for sure. But if you had to, tell me what that kind of looks like. If I came in and I'm like, I want to help, what do you teach them to do? What does the practical work look like?
So the practical work, kind of basically what I did every day was I kind of went over all the forms that needed to be filled out because we just had a lot of data that we were gathering, both that was required to be reported to the state and things like that, but also some of our own things that we talked about. So we wanted to make sure that we were asking the people we were talking to about their resource needs that they might have had, and just making sure that people knew the right questions to ask in order to do that contact tracing. Where did you go? How did you get there? Did you take an Uber? And then trying to get all that information about that Uber driver as much as you can about that. So a lot of logistical things to kind of go through that training. But I think we were really lucky in that medical students know how to get, how to get a good history of presenting illness. So they did a phenomenal job. And it was very simple for them to be able to gather that symptom history because that was, something that we reported to the state, but also internally we were using to understand, how were people presenting with their symptoms? And then additionally, their past medical history. It was very easy for students to be able to do that.
Yeah, again, students don't give themselves often enough credit because medical education is, a professional graduate kind of program. But like when you really think about what doctors do once we close that door or open the door and go back to our computers to document, the things you learn related to, just human relationships and interpersonal skills. Well, hopefully people are learning that. Sometimes that's more innate, it seems, than can be taught. But the things you learn about how to be a sleuth, how to ask questions, and how to, set somebody at ease to be willing and trust you to answer things. How to construct and organize your thoughts in a way that can be written down or communicated to another colleague. Like these are, lots of things you kind of learn by osmosis, if you will, throughout medical education. So there's lots of opportunities here. And I think the HSS curriculum that is arising in which we're trying to contribute to disseminating really systematizes some of those things in a way that hopefully will help students become doctors who really lead their organizations as change agents. So leadership, Dr. Gullett, what role does leadership play in I guess adapt in the adaptation process? Because you talk about these tactics meetings, and if you're in leadership and you're probably asking the questions, maybe holding the chalk, I don't know, writing the reports, what makes a good leader able to partner with those who are, I don't want to say below, but I understand that that's probably immediately understandable to those listening, so for somebody who's kind of in a subordinate role.
Yeah, leadership is really important. And, I don't think we spend much time in medical school on cultivating leadership qualities. I think there are opportunities to do that, but there isn't like a leadership course. You get pieces and parts, and then we hope that you also learn by watching others. But, really leadership is, there are a lot of pieces of it that take intentionality, regular intentionality that some formal teaching and training, there are pieces of it too. So for me, I actually took a formal leadership course in my master's in public health program, and it forced me to actually get a bunch of evaluations from people all around who I interact with in different ways. That was years ago. That was like in 2005 or 6. And I've never forgotten that, because I learned things I never would have otherwise known about how I interact with people. And it really helped me realize, how I could be better. And I'm constantly trying to think about and be intentional about how to be more inclusive. And I mentioned psychological safety earlier, but I think it's really important to set a tone when you're in a leadership role, regardless of what that looks like, what context it is, where people know they're safe. And you can disagree with safety. So you can disagree. And let me tell you, in high pressure situations, in a pandemic, there's a lot of disagreement. But you have to be able to disagree respectfully and professionally, and people have to know they're safe speaking up, because if not, it'll be that answer choice C that we talked about earlier, where you're just told what to do, and there is an engagement and investment. So for me, leadership's really, really important. And I've learned from a lot of great leaders in my life, and I've learned from a lot of leaders that I didn't particularly enjoy working with, and a lot of people in between. And I just hope that
to put it professionally and respectfully,
I just hope the students listening know that they're leaders too, and people are already looking at them. And so the things they do are really, they matter for patients already. And they'll be leaders the rest of their career, but we need to help them be better leaders than they would be without feedback and without guidance.
Yeah, absolutely. All right. Well, we have a few minutes left and some questions that we should probably cover that are not case-based, but let's go through them. So, Andrea, do you mind going through these? And Dr. Gullett, if you can expand on the answers that we get?
Yeah. So I think our next one is, what is the most important determinant of a system's behavior? And your answer choices are A, function or purpose, B, interconnections, C, elements, D, events, or E, all of the above.
And the correct answer here is function and purpose. I don't know. These questions kind of drive me nuts, because I'm like, in one sense, I'm like, man, I wish like USMLE questions were like this, because you're like, just grammatically, you can eliminate choice E. But our answer to what's the most important determinant of a system's behavior is A, it's function and purpose. And why is that the case, Dr. Gullett?
Well, this is, I think, all of these are parts of systems. Those are all unique parts of systems. And so this is talking about behavior. So earlier I mentioned that systems get the results they're designed to get. And so we have to understand the components of a system and how they work together to understand what the outputs are. And if the outputs or the function or behavior or purpose is not what we want, then we fix the pieces of the system. So I think that this is just helping us think through just basic understanding of systems and complex systems and how we can change them.
Let's see. We got a couple more. Andrea, what's next? Some more like definitional questions that are great.
Yeah. Next one is, what constitutes a system? And answer A is relationships, feedback loops, reflections. B is parts, connections, and boundaries. C, tools, methods, approaches. And D, interrelationships, perspectives, and boundaries.
All right, Dr. Gullett, what constitutes a system?
So the answer here is B, parts, connections, and boundaries. So systems are collections of a lot of interconnected parts, and they generally have a common purpose. But you have to understand the confines of each of the pieces of the system, and then how they work together.
Can you give an example based on the health department where you guys have worked together of some of the parts, connections, boundaries?
Yeah, I can talk a little bit about it. So I think the most obvious boundary for us was kind of, in a sense, Cuyahoga County. We really tried to limit ourselves to Cuyahoga County since we are the Cuyahoga County Department of Health or Board of Health.
Makes sense.
It made it a little bit confusing, though, because Cleveland Department of Public Health is also in Cuyahoga County, but they themselves are their own jurisdiction. So that made that boundary tricky.
Interesting.
But kind of like how I was talking about before, we had a lot of parts kind of in our system, depending on what you looked at. So some of our parts included kind of our hospital partners, the Board of Health itself, and just the general public, some of those businesses that they worked at, residential care facilities, all of these were parts of our massive system. And we all were connected because we were regularly in communication with all of these groups of people. And there were, communication routes between all of us in order to work together to fight this pandemic.
Yeah. All right. Thank you. Final one. What is our final question to discuss today?
Final question is, which of the following is an emerging property of a complex system? Answer choices are A, nested systems, B, iteration, C, self-organization, D, instability, E, simple rules, and F, all of the above.
All right, Dr. Gullett, lay some wisdom on us.
All right. So it's F, all of the above. I think actually this might make more sense if I tell just a brief example. So in our work at the health department, we've been doing community health improvement planning, which is actually what Andrea did her MD thesis research on. And we've been working with a lot of community partners. This is pre-COVID for a number of years. And the idea here is that we contribute to improving the health of the community, including addressing things like structural racism in our greater Cleveland area. And when we first set out, we realized that, we were all working alone in our silos, and we were doing good work independently, but there wasn't a collective purpose necessarily. And so we've learned over the years, the working together and building relationships, that we've built a system of community health improvement. And that system is complex and it's constantly changing. But we know now that we are working together in ways we never could have dreamed possible before. And that's emerging properties of a system. Like things are changing, things are working together differently. And so you have these jargony words that were here, right? Like nested systems, iteration, self-organization, instability, simple rules. But all 5 of those are things that we actually do in our community health improvement system. And including, we have rules that we start every meeting with. And we talk about how our work is changing and how we're really trying to change the system to be equitable. So that's an example that maybe hopefully helps people see how this could be, thought of in a concrete way. But it's really about seeing how things work differently. And the whole is much greater than the sum of the parts working individually.
Yeah. And of necessity, some of these emergent properties come about because of the very nature of a system being constitutive or constituted by parts, connections, and boundaries. When you have those things, the result is going to be epiphenomena or emerging properties. I love this. If I told you before that, and I say this, I feel like every episode. So people are probably gonna be like, when's this guy just gonna quit doing medicine and go back to doing philosophy? Just this idea of relationality and what emerges from relations amongst not just parts in our healthcare systems or between individuals, but really anything with which a person or other thing can have a relation leads to something greater than just the 2 or more parts together. So if I had more time, I would probably write an essay exploring that relationality, but I probably will have to save it to retirement.
Unfortunately.
All right. Well, thank you so much for your time. If there's nothing else, you guys have a happy set of holidays here. Merry Christmas and all of that stuff. Merry virtual Christmas, probably for most of us.
Christmas,
Right. I know I'm kind of bummed. This is one of my favorite, one of the only and favorite family events that occurs with the extended family in the area. And this year we're not doing it. So making that sacrifice.
But making us public health people proud.
Right. Exactly. And that's not the only reason we're doing it, but it's certainly part of it, right? Couldn't do this podcast and invite you on and be like, all right, I'm out, heading over to a 25, 30 person party with a bunch of people over 50, 60. All right. Well, thanks. And good luck, Andrea, on your education as well.
Thank you so much, Dr. Beeman. I appreciate it.
Thank you so much.